And we have some questions to answer from the report section yesterday, the drug regimen review. I think there are a couple questions in regards to the pressure ulcers. And then Ann is going to speak to the section GG questions that we received. So we'll continue with the Q&A session until about 3:15, and then we'll do a quick wrap-up. And then we wish you all safe travels home at that point. So I'll turn it over.
Hi, everybody. So you had lots of questions that you submitted. So let's do a couple on the reports. We had a question about how does an agency correct erroneous data on the Home Health Agency Review and Correct report. Questions related on how to correct the OASIS data may be submitted to the agency's state OASIS automation coordinator. And there's a list of those that are available on the CMS website. You can pull up OASIS automation coordinators. The best way, though, is really to take your questions related to the quality measure calculations or quality measure reports and submit those to the Home Health Quality Help Desk at homehealthqualityquestions@cms.hhs.gov, and that's in your slide deck on your resources from yesterday. The next question is, how is data corrected? Nope, we're going to skip that one, because we kind of answered that already. There were some questions about access to the CASPR reports. What is the number of staff per agency that can access the CASPR reports? And what do I do if there's already 2 people at my agencies that have access to the reports, but I need them? Does that mean I can't access them? Generally, there's a 2-person limit to accessing the CASPR reports. Agencies with requests for additional staff may contact the QTSO help desk at help@qtso.com with their request and rationale for their request if you need more people to have access to your reports. We had a question, what do you mean by OASIS-based? And how will the ACH data track? Is this going to be on hold? The term OASIS-based related to the quality measure of acute care hospitalization, ACH, indicates that this measure is calculated using OASIS data. The acute care hospitalization measure will no longer be reported in the CASPR reports in 2019, as the OASIS item used to calculate this measure is no longer included in OASIS-D, which is effective on January 1st, 2019. Let's see. How will the, I think this is a question about OASIS-D. How will changes to the OASIS-D with the OASIS-D impact VBP and STAR quality measures? The measures that have been removed are added to the Home Health Quality Reporting Program or the Home Health Quality Initiative, and that are effective with OASIS-D implementation on January 1st, 2019, don't have an impact on the quality of patient care STAR ratings or on the home health VBP model, because these measures aren't currently included in either of these programs currently. Moving on, you had a lot of questions on the skin assessment. So one question was, if a patient refuses to complete the skin assessment, since they're already up and sitting in a chair, can another nurse return in the 5-day period and complete a skin assessment and collaborate? So the assessing clinician may collaborate with a second clinician to gather information to code the pressure ulcer items, as long as the coding is based on the first skin assessment conducted at the start of care, resumption of care. Here's another one. Can the start of care nurse elect not to do a skin assessment at start of care, so there was no skin assessment at the start of care, and allow a second nurse to do it because a dressing can be changed within the 5-day period? So assuming that you're referring to a non-removable dressing that the first nurse is visualizing, the pressure ulcer should be reported as unstageable due to the non-removable dressing or device, as this was the status at the first skin assessment. This is true even if a second nurse observes the wound as a stageable pressure ulcer at a visit occurring within the 5-day assessment time frame. And then here's some on drug regimen review. let's see, so if the clinician sends a fax to the physician, but only gets a confirmation that the fax was sent, but no return of any changes or directions were given, what would you choose? So the communication has to include both the clinician communicating with the physician and also receiving a response from the physician. But it's important to note in this question, they ask if they didn't get a response versus no changes were given. If you speak to the physician and the physician doesn't elect to do any medication changes, that's a two-way conversation. They don't have to make a change. Here's another one. Does there need to be a doctor order by midnight of the next day to answer yes? A lot of times we convey the information in time, but don't hear back from the doctor until the time frame's over. Yes, is the short answer. The communication must be a two-way process. The return communication may not, this kind of pertains to what we just said. The return communication may not be in order for an intervention, but there must be a response prior to midnight of the next day. Does the start of care medication list have to match what the hospital discharge list, or does it need to match what the patient is actually taking? This never happens, right? This is the purpose of the medication review and the medication reconciliation. The role of the assessing clinician is to reconcile these three with the physician to create the final drug regimen that pulls from each source and is then approved by the physician so that you have completely reviewed and reconciled what they should be taking. This was an interesting one. If it's a known repeat patient and the issue has been identified and resolved in prior episodes, does it need to be reported to the physician as a clinically significant issue if the physician has given prior instruction? So, you have to use your clinical judgment if it's clinically significant. If it's not clinically significant, you know the physician's already aware, you know the physician has given orders or not given orders, then it's not clinically significant. So you have to use your clinical judgment in terms of deciding if it warrants physician contact. Does M2005 apply even if the issue was not identified or communicated, happened 3 years ago, before M2001 to M2005 series was in effect? So the question here is about somebody that had a very long-term patient and there wasn't even drug regimen review on the OASIS. What do they do at discharge? How would they answer the question? So M2005 says from the most recent start of care or resumption of care, if you have a very long-term patient who has not had a single resumption of care, then you would need to go back to the last start of care to determine how to respond to that question, even if it wouldn't be included in the measure because you wouldn't have a complete episode to look at, but yeah, you would still need to answer the question. If no significant medication issues are documented throughout the stay, should I consider at discharge that no issues were identified and mark NA? Yes. The answer to that is yes. If no significant medical issues are documented throughout the stay, then at discharge you would mark the item as NA. Please define what an episode is. So a quality episode is designed by a start of care or resumption of care at the beginning, and by a transfer, discharge, or death on the other end. That's a quality episode. Let's see. More on drug regimen review. With drug regimen review, what happens when the start of care is Saturday and the physician should reply by midnight Sunday, but the office is closed? That never happens. And the next question is, how do you suggest reporting these issues on weekends to get a response when physician offices are closed or when the physicians in the community will not give instructions because they haven't seen the patient following their hospitalization? The timelines are clear, and a response would be required from the covering physician. If the ordering physician is not available in that time frame, and if the covering physician does not return the call or declines to give an order for follow-up, you have to answer the question on that basis. And with that, I think I'm going to hand it off to Ann.
Great. Okay. Thank you very much, and thank you. Yeah. Thank you for submitting some great questions for section GG. So we've selected a few to respond to, and we'll provide responses to others, perhaps through follow-up emails or posting. So the first one is what counts as before the current illness: 1 week, 1 month, usual status on the day before the determination of the orders for home health. So our answer to that is, in responding to GG 0100, prior functioning everyday activities, the activities should be reported based upon the patient's usual ability prior to the current illness, exacerbation, or injury. This is the patient's functional ability prior to the onset of the current illness, exacerbation of a chronic condition, or injury, whichever is the most recent. That is indicated in the episode of care. Clinicians should use clinical judgment within these parameters in determining the time frame that is considered prior to the current illness, exacerbation, or injury. Next question. Sorry. Skipped ahead a little bit too much and then back up too much. Okay, next one is, when completing GG 0100 prior ability, will the clinician need to document the patient's safe prior ability? And safe is in all caps. So safety is always a primary consideration. Patients should be allowed to perform these activities as independently as possible, as long as they're performing it safely. So yes, indeed, safety is taken into consideration. What exactly is the definition for the use of the dash? So a dash would indicate that no information is available and no attempt was made to gather information. Next question, is a chair lift considered a mechanical lift? The answer, for GG 0110C, prior device use, a mechanical lift is defined as any device that a patient or care requires for lifting or supporting the patient's body weight. Examples provided included stair lift, Hoyer lift, tub lift. Clinical judgment may be used to determine whether other devices, such as the electric lift chair described, meet the definition provided. Next question. If you cannot assess a patient for one of the GG performance questions, is it better to take the word of the patient family, especially if does not appear to be accurate, or use one of the not available to assess codes? When completing the GG items, combine general observation, interview of the patient and caregiver, collaboration, and other agency staff, and other relevant strategies to complete all OASIS items as needed. Next question, if a goal is set for expected decline in patient status, will that count against the agency for publicly reported data? I did cover the function process measure at the end of the presentation, so if you'd like to review that again, that's slides 205 to 214. And for that process measure, the requirement is to establish and code a self-care or mobility goal for one of the selected few items in GG self-care. So there were 3 self-care activities and up to 9 mobility items. The process measure does not consider whether the coded goal was achieved. The next question was, what if the patient lives by themselves but needs a caregiver to assist? How would you code them in GG 0130 and GG 0170? If you see them complete the activity but it is not safe, how would you code them 6 independent? So as I said before, safety is always a primary consideration. Patients should be allowed to perform the activities as independently as possible as long as they are safe. code based on the type and amount of assistance required to do the activity safely. Next question, is the coding decision tree available somewhere? So the slide decks are available on the website right now, and I know those will be updated with the answers, so those coding questions are available there. Next question, in regards to GGO 130 and GGO 170, can code 10 not attempted due to environment be used for in-home environmental issues such as clutter, hoarding, or would it be preferred to use the 88 not attempted due to safety concerns? So in this case, you would use your clinical judgment to determine which really best applies in this situation, whether it's an environmental issue or maybe there's a health issue that's going on. Next question, does the eating item also consider the meal setup as it did previously? Example, mashing potato, pouring milk, etc. So yes, opening containers, cutting up meat, pouring liquids would all be considered as setup assistance for eating. Next question, by licensed professionals, I assume you mean those identified by OASIS conventions as long as allowed to perform daily data collection, even though LPNs and other therapy assistants are licensed. So the response to that is that CMS has not made any revisions to who can complete the OASIS. Next question, for eating, question GGO 130A, how would we address a modified diet if patient can only eat safely if they have thickened liquids or chopped food, mechanical soft diet, which they are not able to prepare themselves? Would this be considered in the eating question, or is that considered meal prep? So the assessment for the eating item starts once the meal is placed in front of the patient, regardless of the type of diet. So food preparation is not included. Next question, is it true that only one self-care or mobility goal is required for the GGO 170, 130 and GGO 170? So for the function process measure, at least one of the 12 self-care or mobility activities that are included in the measure are coded. And again, I would refer you to slides 205 to 214. And actually, the list of items are on slide 213 and 214. So it's 3 self-care activities and 9 mobility items if the person is walking and using a wheelchair. And so those are the items for that measure. Next question, GGO 130B, patient cannot get to bathroom. So this is the oral hygiene. So helper is bringing supplies to patient. Patient is then able to brush teeth. Is this only setup? Yes. Next question, coding 7, patient refused. Why would one use this option when the clinician has the option to ask family and or caregivers for this answer? So when completing the GG items and a patient refuses to perform an activity, combine general observation, interview of patient, the patient or caregivers in collaboration with other staff and other relevant strategies to complete any and all OASIS items as needed. Code 7, patient refused, would be used when the assessment discussion of the activity is attempted and the patient refuses and no other performance or activity not attempted code is applicable. Next question, OASIS conventions require assessing what the patient usually wears. Does GG dressing item only include what the patient is wearing at the moment of assessment? So the response to that, assess the patient based on clothing the patient routinely wears. Next question, is the intention for home health agencies to be moving from same-day SOC dates to using more of the 5-day window so collaboration can take place to answer the GG questions? And the response to that is no, there's no change. And then finally, for GGO 130G, is donning, doffing, and orthotic still considered a device, or is this considered footwear in this circumstance? So the response to that, if donning, doffing, an elastic bandage, electric stockings, or an orthosis or prosthesis occurs while the patient is putting on or taking off socks and shoes or other footwear, then consider it when determining the amount of assistance the patient needs when coding the dressing item. So Heidi, did you want to add to anything that I covered? Okay, so I think, is Bridget, there we are. So I think we're all done with the questions that we were able to get answers to at this stage. And Bridget will let us know what to do next.
Great, thank you very much. So first of all, I'd like to thank our presenters for the last 2 days. I hope you all enjoyed your time with us. Just as a matter of cleanup, we do have an end of session little evaluation. Again, it's optional, but it is available on Slido. There are 4 questions. You could give us your feedback. We'll keep it open until midnight. Secondly, we do have a few of the packets left over, and if you'd like to take those just as ideas for training, those are available on the sign-in desk as you walk out. Again, we will continue to look at addressing the Q&A, the questions that came in, and those will be posted ultimately to the Home Health Quality Reporting training page, along with the materials with the answers to the knowledge checks and practice scenarios. There'll also be a link from that page to the CMS YouTube site. We will send out an email to everyone who registered for this training when those materials are available on the Home Health Quality Reporting Program training webpage. And I think that that is it. Again, thank you so much, and we'll look forward to seeing you at another training, hopefully.